I'm Brianna Polk, and this is Jenny Bartlett-Prescott. She is the Senior Director of Integrated Health here at Church Health. And right now we're actually outside of our dental clinic in the waiting room. We're at Crosstown Concourse right now, where all of our clinical service lines are located under one roof.
So I've been at Church Health since 1997, so now that's 20 years. Wow. Straight out of college, never worked anywhere else, so I don't know what it's like to have a real job. But I've definitely grown up with Church Health Center. When it first started here, we only had 60 employees, and now we have over 200. So my career has progressed as the organization has grown.
That's awesome. That's awesome. So if you can just tell us a little bit about the clinical lines, clinical service lines that are offered here at Church Health.
Sure. So in Integrated Health, we have several different clinics that we staff with both staff and volunteer providers. The largest one today is, of course, medical. Now within medical, we also have urgent care, primary care, and specialty care within that system. We have dental, which we're sitting out of right now. We have eye clinic for optometry services. We have behavioral health and social work. Behavioral health has both counseling and psychiatry as part of it. And we have physical therapy. And that's how we provide our clinical services. Now at Church Health, we also have wellness offerings through a teaching kitchen and through our children's health programming called The Well. But today we're gonna mainly focus on the clinical service lines and how we run them.
Okay, awesome. So the themes across your clinical service line, volunteer providers, could you just describe that to us, please?
Yeah. So when Church Health first started, and it's important for our echo clinics to remember this, we started in one house, one doctor, 8 patients on the first day. And ever since the beginning of Church Health, the model has been that while we do have staff providers, a bulk of the care we deliver actually is through donated services and volunteers. So today how that looks is in all of our clinics, the primary care that's delivered, whether we're talking about kind of the general dentistry primary care or the medical primary care, for the most part are delivered by staff providers, but then all specialty care is delivered by volunteers and donated services. So in medical, what that looks like is any referral for diagnostic services, hospitalization, specialty consult, is happening through donated services for our uninsured patients. And so volunteers are part of how we staff and survive at Church Health and can deliver a high value of service for a fairly low cost.
So you mentioned donated services, and you mentioned that you have providers who come in or physicians who come in and volunteer their time.
Yes.
What other type of donated services can clinics look for? Does it all have to be medical, like people coming in, or could it be other forms of donated services?
Right. That's a really good question. I think sometimes it's hard to remember that before you buy something, you should ask for a discount or ask for it to be donated. We have had as simple of things like the upholstery of a dental chair that was donated. The chair itself was donated, but it was old, and then we got the reupholstery of that chair donated. Almost anything you can ask for a discount. You will find that we often, even if we have to buy the good, we'll ask for the shipping and handling to be written off. So that's certainly something to expand the thought. And don't be scared. We often tell clinics of not being scared of asking for even the big ask. All of our labs today are donated through Methodist Hospital, and they're able to handle that service for us, as well as, of course, a lot of specialty care and inpatient stays as well. So, it's always something to keep in mind of what kind of relationships do you have, who do you know, what people in the community can support you to do. We've even had patients with huge feet, and we've asked for donated orthopedic shoes to be created for them, or prosthetics. A lot of time it's knowing the story of the person, the story of the ask, and that can go obviously for dermatology and that direct service delivery of healthcare, but it can also go for the in-kind donations of goods and services as well.
Okay, could you talk to us about your teaching clinics that you have at Church Hill?
Yeah, so one strategy that people often kind of go to, because it seems like an easy, low-hanging fruit, is to have learners on site, students, or actually hosting residencies. Mm-hmm. Now today we are into our second year of our family medicine residency, and it's a fairly small residency, 4 residents per year. It'll be for 3 years. So at the largest size, it'll be 12 residents. In dental, we have residents. In our eye clinic, we partner with Southern College of Optometry, and we have a resident. But when we first started, we were not a learning site. There's a cost to being able to provide a rich learning experience. Mm-hmm. And of course, we want to be training excellent providers, right? Mm-hmm. So that's something to keep in mind, is what kind of services can you provide your learners while still maintaining the high quality care. There's an administrative oversight to that. So we proceeded into that with caution, and as we got more mature and more developed, we were confident that we could do that. The other thing I would just say, as far as making a decision about being a host site for learners, for residents, is that balance of where the primary purpose of what you are doing is teaching, and the primary purpose of what you are doing is delivering high quality care, and being able to hold both of those in balance to each other, because you want to do both really well. And if you get out of balance, you're either not going to provide the training you want to provide for those practitioners, or you're not going to be providing the quality care that you necessarily want to provide. So that's just something to know on the front end too, is how will you keep both of those things kind of hand in hand and equal to each other.
Okay. Jenny, can you tell us about your evidence-based practices and data-based decision-making?
Sure. Again, that's something that we have grown more into the more mature we got as an organization, but this is definitely something that, in fact, I just spoke at a conference last week for a lot of new free and charitable clinics, and being able to start out with a framework where you are using best practices for guiding the kind of services you're delivering, the kind of care you're delivering, as well as a way to capture data. Highly recommend every clinic start with some form of an electronic medical record. It is hard to know the kind of care you are delivering outside of just your anecdotal stories if you can't pull that data and those results from a database. And that's been, I think, a real key element to our success in the past 5 to 10 years, has been really utilizing our electronic medical record and utilizing the resources that are out there in the community that have already done the research of the best way to approach diabetes or hypertension or whatever it might be. And you can put the two of those together to make sure you're doing those things by pulling data from your own database and comparing it to the standards that are part of your profession. I think it's critical to any clinic, really, in having a good framework for operations, and it's something that we really value and invest in here. Now, what has driven a lot of that is the formulation of something called the Model for Healthy Living. We started that years ago as part of our approach to having a more patient-centered approach to our delivery of healthcare and a more integrated approach. I just listed all of those clinical service lines we have, and mentioned that we also have wellness services that we offer related to physical activity and nutrition. And so how does all of that come together into creating a framework for a patient's healthy life? And medical care is just one wedge of that. We have 7 components to it when we developed the model that we feel really come together to create what would be called healthy living. So medical care is important. The medicines and going to the doctor and taking care of your teeth and making sure your eyes are still working the way they should. But that's just 1 out of 7 things. Faith life, we feel, is a very important part. And a lot of times faith has been separated out from any discussions in any kind of healthcare clinic. That's one thing we really try to do here is bring that back. Let the person, the patient, bring all of who they are into that exam room. And so faith life is another component with that. Obviously what you eat, nutrition, how much you move, with movement and exercise, your emotional health, your family and friends, your social support, your network of people that you rely on, your work life. How do you use your skills and your talents? How do you support yourself? Yes, but also just, volunteerism can be part of that too. All of these things play a component into whether our patients or us are experiencing what we think really is the life worth living, the healthy life. And so our challenge is, how do we kind of have that frame of 7 conversations possibly that can be going on in one visit, along with best practices, and then how does the data that we pull support that we are truly kind of making that model for healthy living come alive in every visit. We have all the puzzle pieces here. We're fortunate to have that, but the challenge is kind of lining them all up and getting all those puzzle pieces in the right order for that particular patient situation, what they're interested in working on, and what their goals are. But we feel that the model for healthy living at least helps create at least an initial structure for that conversation. And it may be that you just tackle 1 or 2 of those wedges in one visit, but we try to have it be present in all of our exam rooms and operatories, in our waiting areas, just to get people thinking about it. This is more than just coming to talk about what pills you need to take. This is to talk about all of these components in your life.
So Jenny, you've given us the rundown of all things church health when it comes to clinical programs, but what would you give attendees or listeners or viewers, what would you leave them with about their next steps? Like, what can they do next after hearing your talk?
I think that one of the things I've learned in working here for 20 years is much of what we do, whether it's raising money, recruiting volunteers, or even how we provide care to our patients, is relationship-based. And developing those relationships, being very person-centered in how you move forward in developing your clinic, to me is key. But that's also very local. And I think one of the dangers that people can do is try to take the model that we've created here in Memphis and try to plop it down wherever they are. And that may or may not work. So I guess part of this is a little bit of caution of paying attention to your own setting, paying attention to your own community and the relationships that you have built there, following where your current relationships are with how you proceed, starting where you're strong. That's often what we tell our patients when we're looking at the model for healthy living. Let's start where you're strong. So that would be one of the biggest pieces of advice I would have. The other thing, I think I've already mentioned, but it's starting small. If something is feeling overwhelming or feeling too big, pulling back, starting small, starting to where you have the connections, where you have the resources. And then the last thing that I would say, and this is something that took us a while to do, and again, as a new clinic, I would certainly recommend, is not only team-based care in that the provider can't do it all, and having health coaches and breaking the mold, creating the team that you actually need to make that model for healthy living come alive, but also including the patient in that team. The earlier that you can bring patient voices and patient perspectives into how you design your clinic and how you provide the services, and have them being part of your planning and your evaluation and your decision-making processes, I think is critical. It's critical to the success of any clinic. And so that would be kind of my 3 elements, I guess, to remember as people proceed into the wilderness of starting a new clinic.